So hemophagocytic lymphohistiocytosis in the ICU is an unrecognized syndrome. To tell you the truth, I have missed it. And I have missed it because I don't have the tools really to diagnose it because the patients, when they arrive to the ICU and have inflammatory responses, like, the ones that we see in sepsis or in a viral infection, they all look very similar. I don't have any conflict of interest to disclose. And basically the objectives are three. One, you don't hear it? Sorry. ¿No hay traducción? Bueno, it's gonna be difficult. Bueno, lo tratamos a ver. Entonces, voy a tratar a ver cómo va. Entonces, ¿sí hay o no? Okay. So basically, describe the syndrome first, and discuss the management and see where we're going from here. So if we look back at the history of HLH, let's gonna call it in simple terms, so we don't complicate too much with words that are so difficult. You can see that it was first described in the 30s, and progressively over the years, as they go, they can change the name again and again and again and again. And in 93, we have this macrophage activation syndrome, the MAS, that we have heard so much about recently. So the discovery of the gene mutation was only in the 90s, at the end of the 90s. So it's only about 24 years, 25 years. You have two syndromes. One is primary, another is secondary. You can see here the different diagnostic criteria applied since the 90s, 94, 97, 97, 2004, etc. And people continue to use the 2004 mostly. You look at what are the characteristics. So you have a molecular diagnosis, usually in the primaries, because you don't have a genetic dysfunction when you have a secondary syndrome. But otherwise, when you look at the clinical syndrome, you look for fever, splenomegaly, cytopenias, meaning anemia, thrombocytopenia, neutropenia, high triglycerides, low fibrinogen, hemophagocytosis that you can look at, peripheral blood and look for the cells devouring each other, high serum ferritin, abnormal liver function tests, etc. You can see that the number of publications using the 2004 diagnosis are much higher than the rest. So let's gonna go back, and when you look at all these HLH names, one of them, the most important, is this MAS diagnosis, the macrophage activation syndrome, which is kind of like the initial phase, basically, of the HLH. You don't have HLH without a MAS. You don't have if you don't have macrophage activation syndrome or the activation of the macrophage, you don't have HLH. So here you have it. There are many presentations. You have this presentation in which basically you see a damage to the, mediated by cytokines, interferon gamma, other cytokines like the colony stimulating factor of the macrophage. You can have a cytokine storm with a leak syndrome, or you can have a multi-organ dysfunction type of pattern after an infection like you see in sepsis, but particularly in viral infections. And you can see like a viral infection with macrophage activation of the coagulation system and producing thrombosis, etc., or diathesis with hypofibrinogenemia, like you see in dengue. Then the three systems that are basically affected are the bone marrow, the liver, and the spleen, as you can see here. And the picture is persistent, this one. So you have a macrophage that is liberating all these cytokines, IL-1, IL-6, IL-18, M1 macrophage, GM-CSF, and interferon, etc. And in the other side, interleukin-10, which is trying to balance the picture, trying to reduce the inflammatory response, okay? But usually is inefficient. Then you have the different areas that are affected. You could have the intestinal epithelium, and then the release of the IL-18, leading to the activation of the macrophage, or from a tumor like lymphoma or myeloid malignancies. You can have other types of activation of the macrophage system by, for example, the activation through the toll-like receptors in viral infections. In this particular case, you have a SARS-CoV-2 infection. You can have the initial response, a first wave of inflammation, and then a second wave of inflammation we see so frequently. So this HLH has become very famous now with the last 4 years of COVID that we have had. First, the descriptions of this multi-system inflammation response in kids, the MISC, and the mass report in the adults, which is basically this reaction, the liberation of cytokines with an increase in the ferritin, cytopenias, etc. With the introduction of all these immunotherapies that we are talking about, this problem has become much more frequent because we are seeing this every time that we use immunoeffector cells, like in the CAR T cells. CAR T cells that I mentioned before, earlier, were actually invented or developed in the early 90s. And in the last 30 years have had a tremendous evolution. Now we are in the 4th generation. And in the United States, basically we are using Kymriah and Yescarta, basically are the main ones. It's impossible to pronounce these names, but basically you use them in lymphoma, leukemia, et cetera, et cetera. And what happens is that you take a patient, you draw blood, take the T cells, then manipulate them genetically with chimeric antigens, and then you grow them in the lab, you put it in a blood bag, give chemotherapy to the patient, and then reinsert the T cells. And when you insert the T cells, now you have a cytokine storm. And what happens is that all these cells getting in the system, then you have different syndromes. You can have HLH associated with the malignancy itself, or you can have HLH produced by the immunoeffector cells that you just injected. So you have the HLH, or you can have ICANS. You can have a systemic response with CRS initially, and then the HLH. And you can have a neurotoxicity event, which we call ICANS. So basically, you have here the definition is an hyperinflammatory response, which is a syndrome, is not a disease. Is manifested mainly, as I said before, with macrophage activation. And in this particular case that we are talking about today, are basically associated with immune effector cells. And what you see is cytopenias with anemia, thrombocytopenia, neutropenia, which you could be thinking that was because of the chemotherapy. Then you see the ferritin levels going through the roof in the thousands. You see a coagulopathy with low fibrinogen, like a DIC type of picture. And then you see transaminitis. You see a liver dysfunction that is sometimes extremely serious. Usually happens after the initial CRS, the cytokine storm, can follow a few days later, like 3 days later, or 7 days later, or almost 3 weeks later. Now, there are some cases where they superimpose this, but they are trying to, some task forces have been trying to differentiate the HLH from CRS, which I think is something that has the same basis. So you have here the two basic forms of HLH, the primary and the secondary. In this particular case, I just put the example of the immunoeffector cells. So the primary, you have an abnormal T cell with a genetic abnormality that leads to a dysfunction of the lymphocyte that gets activated. Then releases interferon gamma, activate the macrophage. The macrophage releases all the cytokines that at the same time activates the T cells. And then you have a vicious cycle of inflammation that IL-10 is trying to control, but is insufficient to fight all these cytokines that are being released. In the case of the secondary HLH, what you have here, you inject all these cells and they come ready to kill the tumor that they were prepped for. So they enter the blood circulatory system and immediately go looking for all these tumor cells and immediately start a cytokine storm with interferon gamma release, macrophage activation, release of all these cytokines. Again, the same cycle, but the trigger was the immune effector cell. So basically you have a macrophage activation syndrome with certain other characteristics like all the dysfunctions that we just mentioned before. The grades are like we mentioned earlier, basically goes from grade 1 asymptomatic or mild symptoms to death. And basically patients hospitalized when patients could be hospitalized even when they are grade 1. But what happens is that grade 3 all these patients come to the ICU. In our hospital, all the patients with grade 3 cytotoxicity of any type come to the ICU. This is the 2004 criteria, basically the list that I mentioned before, the high fibrinogen, the high triglycerides, the low neutrophils, platelets, hemoglobin, etc. There are scores. I don't use the scores. The scores are, like telephone numbers to me. The most common manifestation then, so we have it clear, is elevated ferritin, resolving or resolved CRS. The fever today is not considered one of the diagnostic features of this syndrome. Hypofibrinogenemia, hepatic transaminase elevation, hemophagocytosis in bone marrow or other tissue, and cytopenias. Almost every single one of these patients have cytopenias, but they can have LDH elevations, other coagulation abnormalities, elevated bilirubin, splenomegaly. They can also have fever, neurotoxicity, pulmonary manifestations. The patient may be hypotensive, they may be with altered mental status, may develop renal insufficiency and have high elevated triglycerides. Some components are very characteristic, as I mentioned before. The cytopenias are like basically 100%, and hyperferritinemia is almost 100% of the patients, 99, 100%. Sometimes the discussion is about what is the actual level of ferritin that you need to actually diagnose, but no one can agree to the threshold. There are other diseases that have high ferritin levels. As you can see here, this paper, hyperferritinemia causes and significance in general hospital. You can see it in HIV infection, hemolytic anemia, HLH, basic associated with rheumatologic inflammation, renal failure, et cetera, et cetera. This is a paper that I found recently that this author reports in 4 patients that were young teenagers, and says that this is not being previously reported. I don't know what literature he was reading, but if you look about the type of patients he had 2 patients with COVID, patients with transplants, stem cell transplants, and all the patients have inflammation, HLH or cytokine storms. And with the ferritin, the problem is that it's an inflammatory marker. It's elevated in all type of inflammations. So you can have, you can see that it affects several systems. Anytime there is inflammation, ferritin and epsidin increase, and the macrophage start to grab all the erythrocytes, and you have what is called anemia of inflammation. The ferritin metabolism is kind of complicated, but you can see the intracellular pass when the transferrin brings the iron into the cell, and ferritin is liberated here down there in the cycle. There are many papers that have been published in series. There are a couple of series that have been published recently in the last 8-10 years, mostly from Europe. This is a French study from 2015, and you can see the type of patients. And what we see is basically the same characteristics that we noticed before. Importantly, the patients that die, 90% were intubated, 85% were on vasopressor. So the patients that actually die were very, very sick. The mortality reported in the ICU was about 40%. As you can see here, 28-day mortality, 40%, but the hospital mortality is 70%. And of course, depending on the type of patient. If the patient is intubated on vasopressors and renal replacement therapy, those patients are gonna have a higher mortality. Infectious causes could be triggers for the disease: bacterial infections, viral, fungal, vector-borne infections, parasites, mycobacterial, neoplasias, as mentioned before, even Epstein-Barr virus associated malignancies, or autoimmune cases, etc. This has been reported in dengue, has been reported in COVID, as I mentioned before. The way it acts in COVID is that the SARS-CoV-2 virus gets linked to the AC2 and release the single-strained RNA that is detected by toll-like receptors, and they immediately start the cytokine storm, activating the macrophages and the lymphocytes. There are two big groups mentioned in the literature: the loss of function and the gain of function. The gain of function mostly in all the immunoeffector cells, infections, etc. And you can see here the two groups. This is the CAR T cell gain of function as an example, how it works, and interferon gamma release, macrophage activation. And this is the chain which can be treated with steroids, monoclonal antibodies for interleukin-6 mainly, and the ones that are T cell loss function because of a genetic disorder, then have a chronic course. You require anti-cytokines, antimicrobials, immunosuppression, etc. You can see it also in leukemia, like in this particular case. This is a prognostic factors of early death in a cohort of 162 adult hemophagocytic syndrome patients. And basically, again, there is not much to show you here because the disease is basically an inflammatory process with all these organ dysfunctions. But the malignancies associated with HLH have a lower survival rate than the patients that develop the syndrome because of infection or other immune disorders, underlying immune disorders. Monitoring, well, you monitor the CBC because the patients are anemic, thrombocytopenic, etc. You monitor the coagulation, you monitor the liver function, etc. There are other tests to do, but they are much more complicated. And the treatment, you treat hemoglobins less than 7, platelet count less than 50 if the patient is bleeding. We usually transfuse patients when they drop below 12,000 or so. G-CSF is being used, although there have been some reports of patients getting worse after the injection of G-CSF. Coagulopathies are aggressively managed with cryoprecipitate in those patients with fibrinogen lower than 150 or 100. If the patient is not bleeding, INR, you usually treat with vitamin K, etc. The usual care, you know, it's basically supportive care. Now, if you want to treat the disorder in itself, the recommendation of this task force, this paper was published about 3 months ago. It's a task force of the Transplantation Cellular Therapy Organization in the United States. It was like 50 experts that deal with this every day. And the recommendation is to start with anakinra first line and second line with corticosteroids, increasing the dose, as third line ruxolitinib, which is a JAK1/2 inhibitor. So when you look at how you start the first line with anakinra, plus minus corticosteroids. If it doesn't respond, then you increase the dose of anakinra and add corticosteroids or steroids if you haven't started yet. And as third line, you go for the JAK1 or 2 inhibitors. And of course, supportive care, etc. And you give antibiotics, of course, because usually these patients have some type of infection. A quarter of them have usually an infection that has been identified. So what is anakinra is an IL-1 receptor antagonist, and these are the doses for adults and pediatric patients. In these patients, you have to consider antifungal therapy, HSV prophylaxis, CMV, preemptive therapy, and monitor weekly reactivation of all these viruses. Corticosteroids, there is not much to talk about them, but you also have to consider the fungal infection and viral reactivation and PJP risks. So therefore, you have to use prophylaxis and antibiotic therapy. The treatment, as you can see here in adults, dexamethasone 10 to 40 milligrams a day, Q6 hours. In the pediatric patients, different doses, and methylprednisolone. In the case of the ruxolitinib, inhibiting JAK1 and 2, you can see also infection risk for tuberculosis, fungal infections, bacterial, viral, protozoal. So you have to consider all those. We usually have the infectious diseases team following patients with us. And this is emapalumab. It's a human immunoglobulin with anti-interferon gamma actions. And it's being considered to add, although it has been used in kids without very good response. Etoposide has been used in kids for many, many years, and it's kind of the last drug that we use these days. And the reason are two. The first reason is because it has a 5% chance of producing a secondary malignancy, like in acute leukemia. And the second is that it actually can destroy the CAR T cells. So if you are treating the patient for cancer and you're giving CAR T cells, you don't want to destroy the CAR Ts. You want to control the inflammatory response without destroying the CAR T cells. But if you don't have any other option, what you do is you use etoposide, or you can use one of those monoclonal antibodies to switch off the CAR T cells. You can turn them off if it's necessary. The prognosis is, as I mentioned, about 40%, depending on the type of patient. The patient is in the floor, grade 1, grade 2. As the patient becomes more toxic and has a higher grade, the mortality can go up to 72%. So basically, I have talked a little bit about MAS, HLH, what we are seeing in the ICU on these past few years. I think I missed a lot of cases a few years ago. I wasn't paying much attention. The other problem that we had is that we were not doing all these cytokines panels that we are doing these days. And we have to thank COVID for it, because when COVID appeared, people started to describe these mass type of reactions, the macrophage activation syndromes these patients were presenting, and we started to use tocilizumab in these patients. So tocilizumab to control the interleukin-6 was very frequently used in our hospital. The reason we were not using it much more massively was because, one, it was a very, very expensive drug. Two, there were not enough reservoirs of the drug. We didn't have enough, and we have to use it for the actual cancer patients. And we had to identify specific groups of patients that actually have very strong signs of CRS or cytokine storms to use the anti-L6. So I say that we need to keep this disease or syndrome in mind all the time. Every time we have a patient in the ICU with a hyperinflammatory response, is a type of patient that you need to think about checking the levels of ferritin and do a peripheral smear to look for macrophagocytosis, hemophagocytosis, and other signs of the disease. I think that cytokine panel would be great if you have the capability to do it, but it's not going to help you immediately. So the diagnosis is going to have to be clinical and suspicion. It's going to be very hard for you to wait until the cytokines come back or wait for a particular level of ferritin. Let's going to say that your ferritin levels are 4,000, 5,000. Well, you say, well, but it hasn't reached 10,000. Maybe this is not it. It is. So you need to consider the disease immediately as part of a syndromic clinical pattern. And I think I will stop there. Thank you.